Viewers, hi to everybody. And today's topic is actually of immense importance to most of the practitioners, especially physicians and intensivists, and even other specialties because septic shock transcends all specialties. So I'll start now. It's a kind of going to be 1 hour presentation because it's a very vast topic, and I thought all this is necessary. We'll take any questions in the end.
Yes, sir.
This free channel Young Indian Intensivist on YouTube, and you are welcome to join it or view the videos on it. There are around 320 videos in critical care and allied fields by the best faculty in India and abroad. Thank you very much for giving me this opportunity. Host response to an infection leading to organ dysfunction with increase in SOFA score is derived from the Greek word sapien, meaning to rot, and key and central to sepsis is a vast array of cytokines that are secreted, and we must be aware that the etiology is not only bacterial. There can be viruses, there can be fungi, there can be other microorganisms as well, parasitic, etc. So in today's world of technology, we are forgetting to do a proper history and examination, but please do a proper history and do the examination in the patient when he comes to you. And classic presentation is fever, tachycardia, tachypnea, oliguria, and altered sensorium. And we must realize textbooks and common literature says that these patients present with warm shock. However, warm shock is not seen in all the patients. Some patients are cold when they present or can become cold during the course of the illness. We shall delve into this a little more towards the course of our lecture. Now, as far as the sepsis itself is concerned, we have this response from the host. That is very important, and that depends upon the predisposing factors such as presence of CKD, CLD, immunosuppression. As far as diabetes is concerned, many of you may have read that diabetes is an immunosuppressed state. Now, that is not entirely true. It depends on the duration of diabetes and the severity of diabetes. If the diabetes is 10, 20 years, then definitely it is an immunosuppressed state because there is associated neutrophilic and lymphocytic dysfunction. But a relatively recent onset diabetes is not immunosuppressed. Then the amount of infection again becomes important depending on the response of the host. Sometimes a small pneumonia can have a very severe septic shock, while a large pneumonia may not have. That depends on the response of the host, the genetic interaction, and the number of organ failures determines the prognosis and the outcome. Now, what are the organ failure in sepsis? We have ARDS, and around a year back, a new definition has come up with ARDS. In that, now you can use the ultrasound also. It's not just the X-ray to look at the infiltrates. Then you can use the saturation by the pulse oximetry to FiO2, and it's not just the PF ratio, that is the oxygen by PO2 by FiO2. You can also use high flow nasal cannula for the definition, and you can also use patients without any measurable PEEP. Earlier, PEEP of more than 5 was required. So some new points have been added to a definition, trying to kind of define more patients with the ARDS who are not defined earlier. Now, AKI is another thing that happens in around 20 to 30% of the patients, and they have a worse prognosis. Shock is the topic for today, and 30% of the patients develop cardiomyopathy, which may be as early as 24 to 28 days, 24 to 48 hours, and some patients may actually present with cardiomyopathy, and this mimics myocardial infarction. Acute myocardial infarction, especially the painless one, is a differential diagnosis for septic shock. Encephalopathy occurs in a significant number of patients, and this is due to the cytokines mainly. But very important to realize sometimes there can be focal deficits, and even cerebral abscesses have been reported in encephalopathy. DIC is again a common feature, and some new developments have occurred. We shall see that in the end. And then there is liver involvement in terms of either septic or ischemic hepatitis. As far as septic hepatitis is concerned, it is an condition. It is more of a cholestatic picture with a rise in alkaline phosphatase and bilirubin. OTPT are not affected that much, and if you are getting high bilirubin levels like 20, 30, or even 40, it is consistent with septic hepatitis. Do not think that this cannot be septic hepatitis, because that comes into the differential diagnosis sometimes, and the patient may have predominantly liver involvement. As far as ischemic hepatitis is concerned, Ischemic hepatitis occurs because there's a sudden drop of blood pressure, there's hypoxia in the liver, and in this situation is mainly SGOT-PT, and they can go up to thousands. But if you revert the hypertension, this comes down very quickly. Otherwise, if it persists, this can again lead to acute liver failure. Now, just a word about pathogenesis, a snapshot of this to give you an overview of the pathogenesis. So, if you look here, this is the pathogen at the lower left corner, and this interacts through the PAMs. PAMs are protein-associated molecular proteins which are highly conserved in nature, present on these bacteria, and they interact with the innate immune cells through toll-like receptors and other receptors. Once there's interaction, there's release of inflammatory mediators, which is various cytokines. There are multitude of cytokines, and these cytokines are so large and so complex is the interaction that is why it is so difficult to find any kind of treatment, any kind of molecular treatment, any kind of drug for the treatment of septic shock, because this is really complex. Then when these cytokines are released, it leads to inflammation and damage to the tissues, and this releases what is called DAMPs, damage-associated molecular proteins, which further amplify the signal, the inflammatory signal. And downstream, then this spreads throughout the body, and you get coagulation problems, and there's nitric oxide release, which causes vasodilatation in the capillaries, and this leads to hypotension. At the same time, there's damage to the endothelium, and there's leakage of fluid leading to tissue edema. So this is the cell here, and there's tissue edema, and there's decreased diffusion of oxygen because of edema and decreased availability of oxygen to the cells. At the same time, there's microvascular shunting, there's thrombi formation, which further impairs microcirculatory flow, impairing the diffusion of oxygen to the cells and tissues. And at the same time, there is primary mitochondrial dysfunction because of the cytokines. So this is just to give you a snapshot of the pathogenesis, which is very complex and which itself is a lecture by itself. Now, coming to more relevant things at the bedside, one has to send some labs. So you send the routine labs, and please do the echo. Don't forget to do the echo and ultrasound abdomen, because sometimes the focus in the abdomen, and if you're not finding any proper source and there are some abdominal signs, do a CT also, because sometimes CT reveals the focus of infection. As far as sepsis is concerned, CBC is very important, and all patients will not have a high TLC. Around 30% have a normal or decreased TLC, and if a patient on the other hand comes with a fever and raised TLC, do not think it is always sepsis. There are sepsis mimickers also, which come with fever and high TLC. As far as procalcitonin and CRP are concerned, their role has become less important now, as it has been realized that both can be negative in cases of sepsis, and 20% of the patients with sepsis have a normal procal and CRP. At the same time, there are many causes which can elevate procal and CRP other than sepsis. The list is large, such as myocardial infarction, such as trauma, such as burns, such as pancreatitis. They can all elevate procal and CRP. So procal and CRP have a false positive and a false negative. CRP is just slightly less accurate than procal, but CRP is much less costly. So it's worthwhile to do CRP also. So you may ask me, what is the role of these two markers in today's world? So one is, if you do serial values, then if the patient is improving and there's a sudden jump in this, and the patient also starts deteriorating, you know something has happened, probably an infection has set it in the ICU. Second thing is, it helps in stopping the antibiotics. If the procal is 20% of its initial value, admission value, and the patient has improved clinically, you can stop the antibiotics. So these are the main reasons why we do procal and CRP now, apart from the fact that it does help in diagnosing, realizing the caveats that we have. The new molecule that has come up is presepsin. So presepsin rises very fast within 2 hours of the onset of sepsis, and it is more accurate than procal and CRP. It is not widely available yet, but yes, it is becoming available and should be easily available soon. So the holy grail for sepsis continues. We do not have a perfect marker, but presepsin is definitely more promising. Then we should do the lactate intermittently, and culture should be sent as relevant, definitely blood and urine, and maybe respiratory or others as required. And blood and urine culture should be sent before the antibiotics are started. That's very important. Send it before the antibiotics, and as soon as possible, because antibiotics have to be started as early as possible. Then the new thing is PCR multiplex. So PCR multiplex should be done on the blood samples, because It has a very fast turnover. Within 6 hours, normally you get the result, and after that you get the sensitivity also. And the two common ones which are being used are BioFire and SEPTIMAX. They are validated. BioFire is very accurate, but it takes a little longer than SEPTIMAX. SEPTIMAX accuracy and sensitivity is a little less than BioFire. Now, sepsis is like a house on fire, and you got to extinguish this fire. So, how do you extinguish this fire? The mainstay is antibiotics. So, we have to get the antibiotics in as quickly as possible. And how to select initial antibiotics in septic shock? Ensure the clinical diagnosis of sepsis. That is very important. The patient should not be having any other condition. Please remember there are 15% sepsis mimickers. Okay, various conditions can mimic sepsis. There can be tropical infections. There can be viral sepsis. It has been seen now that around 20% of pneumonias coming from the community can be viral pneumonias. And then there can be other types of shock also. For example, painless myocardial infarction can mimic septic shock. Then what is the source of sepsis? You have to see that, because ultimately antibiotics will be decided by that. Lungs, kidneys, abdomen, soft tissues, lines, devices, and meninges should all be looked at. And sometimes you will not get a source in a small percentage, and this is unknown sepsis. Risk factors should be seen: severity of infection, dual gram-negative cover, and what about the role for gram-positive? So gram-positive here refers to staph. There's a tendency to start teicoplanin or vancomycin in all the patients along with gram-negative cover. This leads to worse outcomes, and this is stated clearly in the sepsis guidelines. Do not give gram-positive blindly. Only if you think there's staph involvement or any other gram-positive, it needs a specific gram-positive antibiotic, should you give a gram-positive cover. Otherwise, a dual gram-negative cover should be started empirically. Then the dose is very important. You should give the highest doses possible for your patient. Now, this is a very important thing, that do not decrease the dose in acute kidney injury or the patient has CKD in the first 24 hours. And this is very well established. And again, there is a problem here, because people tend to give lower doses in the first 24 hours if there is AKI or CKD. No patient dies of a higher dose of meropenem. Rather, the patients die of lower doses. It has been seen that patients with AKI have a worse outcome in sepsis because one of the reasons being that the serum antibiotic levels are low. There's a tendency to underdose. So please give full dose in the first 24 hours, and then you can modify. And for starting the antibiotic, what antibiotic? Well, there's no clear one antibiotic. You have to go as per the resistance patterns from the antibiogram, from your microbiologist. The microbiologist, depending on the number of cultures over the last few months, last 1 year or so, will have an antibiogram, which will state what organisms are coming from the community, what are coming from your hospital-acquired infections, and what is the sensitivity pattern. So you have to look at this and then start the antibiotics, and 2 gram-negative antibiotics should be given in the beginning. And one has to look at the side effects. What are the potential side effects of this, and what is the patient suffering from? For example, if the patient has a history of seizures, then one has to be very careful in starting carbapenems. Then one has to look at renal and hepatic function, because the dosing and drug interactions, if you can be aware of the drug interactions, again it becomes important. For example, if you are starting a drug like azithromycin, which can prolong QTC, there can be a problem in a patient with cardiomyopathy. Now, the thing about de-escalation is, if you get a culture positive and the patient is on 2 antibiotics, please give the single best antibiotic. There's a tendency here again to persist with 2 antibiotics. Do not give more than what is required. It leads to worse outcome. De-escalate. If the culture is positive, give one single best antibiotic. So this is a list of the newer antibiotics I have put up for you. These are all available now in India. And in the era of increasing resistance, these have become very important. So I will not go into the antibiotics, because that is beyond the scope of this lecture. But you can go through this. The recording will be available. These are all available. Some are not so easily available. But if you want, you can get these antibiotics. And this definitely helps in the management. Now, coming to the treatment of shock. So as far as shock is concerned, very important is ventilation, IV fluids, and support to the cardiac pump. So first we'll start with the fluids. I already told you about the antibiotics. The antibiotics should go in as fast as possible after sending the cultures. Now, how much fluid to give as a fluid bolus? First of all, what is a fluid bolus? So a fluid bolus is defined as 4 ml per kg minimum over 10 to 15 minutes as fast as you can give. That is what is the definition of a fluid bolus. Generally, people give 500 ml, but the definition is that much. That much is the least. Now, the sepsis guidelines have defined the initial fluid bolus as 30 ml per kg to go in as fast as possible. But that is not true anymore. The sepsis guidelines came around 3 years ago, and they were heavily, criticized also. So this is now the era of personalization and precision medicine, and we have to individualize. Some patients will require that much. Some patients may require even more than that. Supposing he had a lot of vomitings, there was poor intake for 3-4 days, he may require more than that also. But generally, initial bolus of 1 to 1.5 liters is sufficient for most patients. And after that, one has to assess fluid responsiveness and go further. So do not give 30 ml per kg initially. Give 1 to 1.5 liters in an average weight patient, and then we have to take it further on from there. Now, which fluids? So we have normal saline, ringer lactate, plasma light, which is a balanced fluid. So as you can see, for normal saline, it contains a lot of sodium and chloride, and plasma light has only 140 sodium and 98 chloride. And lactate has lactate in it. So here the problem is that if you give more than 2 liters fast of normal saline, it leads to hyperchloremia. And hyperchloremia has been found to be detrimental. So you do not want a lot of normal saline to go in. And then you can always combine it with some ringer lactate. Initially, some normal saline, some ringer lactate can be given. The problem with ringer lactate is that if you give too much ringer lactate, then your lactate levels will go up. Okay, and if you're measuring lactate to see the progress of the shock, it can interfere with the measurement of the lactate. And the other thing is the potassium in ringer lactate and plasma light has to be looked at. If the patient has hyperkalemia, you have to be careful. After giving the initial normal saline ringer lactate, you can go on with plasma light if the chloride levels are rising. You do not want the chloride levels to go beyond 109. And I should just come to that. Albumin, what about albumin? So albumin has been used as a volume expander, but it has been clearly seen that it does not really make much of a difference to the total fluid that you're giving. Now, what has come up is the role of albumin as a drug. Albumin has pleiotropic properties. It is antioxidant, anti-inflammatory, anti-nitric oxide, immunomodulator. So certain trials have been done, and they have shown that albumin helps in the inflammatory response. And above is the comparison of 5% albumin and normal saline in patients with chronic liver disease. This trial was published from ILBS. And they showed that if you used a lot of albumin in the beginning itself, the outcome was much better. And there are these other trials, smaller trials, which have looked at albumin infusions in the early stages itself, first 24 or 48 hours, and whether it helps. And definitely the inflammatory markers and other things were improved. And there's a strong signal to the use of albumin as a drug. In fact, if you go back historically to the trials for albumin, such as Albios and Dubios and SAFE, there were signals that albumin helps in patients, and this is not because of its volume expanding properties. It does not really help as a volume expander because it leaks out. The endothelium is leaky, and just like fluid, it leaks out. So consider using albumin as a drug in the first 24 to 48 hours. Now, coming back to the story of balanced fluids versus saline. So this is a meta-analysis published 2 years ago in NAGM Evidence. They looked at 13 RCTs and around 35,000 patients, and they saw that there was a 9% relative risk reduction with balanced fluids and 1% increased risk, thus favoring balanced fluids. So what happens is that if you give a lot of normal saline, your chloride levels rises, and along with the rise in chloride, there's hyperchloremia, acidosis also. So when there is a hyperchloremic situation, it leads to constriction of the afferent arteriole. And when it leads to constriction of the afferent arteriole, it worsens renal function. So this is why you do not want to give too much of normal saline, because it leads to hyperchloremic acidosis, and both are detrimental. So a small amount can be used, small amount ringer lactate, but if the chloride is rising, the acidosis is occurring because of that, you have to go in for balanced fluids. And because we give in more fluids, you have to use balanced fluids at some point in time. Now, the other thing which is somewhat new is early use of noradrenaline. So earlier it was recommended you give a lot of fluids, the blood pressure is not coming, you start your vasopressors. The first vasopressor we start is noradrenaline. As far as vasopressors are concerned, it is generally agreed noradrenaline should be the first one. Occasionally, you may use vasopressin if there's a lot of tachycardia. Now, why is noradrenaline helpful if you use it early, and when and what is early? So what happens is that there's a lot of leakage from the fluids, from the vessels, the capillaries, so they are empty, right? And if you use noradrenaline immediately, it can lead to closure of the capillaries, the collapse of the capillaries, because it will constrict. So initially, you should give some fluids very fast, at least 500 ml, and then depending on how bad the patient is. So you look at the diastolic pressure. The lower the diastolic pressure, more vasodilated the capillaries, and if they're grossly vasodilated, then it will take a lot of time for fluids to fill up. So here, vasopressor giving early helps in vasoconstricting the vessels, the capillaries, and raising the blood pressure. Then again, if the patient has ARDS or raised intra-abdominal pressure, then you don't want to give too much fluid. Here again, you should use noradrenaline. And then there's something known as shock index, which is the heart rate by the blood pressure. And if that is more than 1, here again, you would like to use early noradrenaline. Noradrenaline helps if you give it early because of a couple of reasons. It causes venoconstriction. And there's a lot of fluid in the venous system. 70% of the fluid lies in the venous system. So the venous system constricts and there's increased venous return. Apart from that, noradrenaline has a beta-1 action on the heart. So when it has a beta-1 action on the heart, it increases the contractility of the heart. So these are 2 reasons why noradrenaline really helps, and it also constricts the peripheral vessels, the peripheral arterioles, and brings up the blood pressure. And it has been seen actually in a meta-analysis also, and the first trial which was related to this, the sensor trial, around 5 years back. That noradrenaline, if you give it early, it reduces the total amount of fluid that you are giving, and it is actually associated with better outcomes apart from decreasing the amount of fluids. So definitely, this is the way to go now, to use early noradrenaline. Give some fluids, 500 ml or maybe more, but within the first 2 hours, your noradrenaline should be going in. Now you have given the initial fluids, right? The bolus has been given. Further, after that, you have to assess for fluid responsiveness. If the blood pressure is not coming up or if the patient is not doing well, you have to see whether the patient will respond to more fluids. If the patient is doing well, blood pressure is stabilizing, then no need to give fluids as a bolus. You can just put on maintenance fluids. So how do you assess fluid responsiveness, and what percentage of patients are responsive to fluid at this stage? So it has been seen that after the first bolus, only 50% of the patients are responsive to fluids. That is fluid bolus. So what parameters are used? There are clinical parameters, there are static parameters, and there are dynamic parameters. Clinical parameters: BP, pulse pressure, urine output, mentation. So these can be used in all ICUs who do not have any kind of advanced monitoring. The static parameters are the size of the CVP, and on focus, you see the CVP, and on focus you see the IVC size, and you can use the echo also to see if the ventricles are small and contracting well. What is the contractility? So as far as CVP is concerned, just the number on the CVP is not really helpful, apart from the fact that if it is less than 4. If the CVP is anything from 0 to 4, that means definitely it will be helped by giving fluids. Other than that, a number from 4 to 14, 15 can be anything. Whether this patient will respond to fluids or not, we do not know. The number from 8 to 12 is fallacious, which is written in many books. Keep the CVP from 8 to 12. That is actually incorrect. A CVP less than 0 to 4, yes, the patient will respond to fluids if he needs fluids. From 4 to something like 14, 15, the patient may still respond to fluids. And those patients, who are having 10, 12, 13, they are patients with right ventricular disease. So these patients will have right ventricular disease, CVP will be high, but they will still respond to fluids. And IVC size, which is again seen by some practitioners, is not helpful, because IVC size varies depending on the size of the patient, the height, the weight, etc. And it is a static parameter. So IVC size is not to be seen. Echo, I have already told you can see if the ventricles are small, and you can use the echo to some extent if you are good with the echo. The dynamic parameters are the best to use, and this is actually real-time assessment of how much fluid the patient requires, because here the heart-lung interaction comes into the play, and it's in real time you assessing the fluid responsiveness. And what is used is PPV, pulse pressure variation. These patients are typically supposed to be on the ventilator. They're supposed to be paralyzed, and there should be no arrhythmias. and the tidal volume should be 8 ml per kg. So here, if the pulse pressure variation is more than 13%, they will respond to fluids. And this 13% is seen on the cardiac monitor. You have to have a cardiac monitor in place. If you do not have a cardiac monitor, then you have to take a strip from the monitor, and then you have to calculate. There's a formula for calculation. You can see that. I cannot tell this here because it will go into too much of extension of time. Then IVC collapsibility is the other thing you can look at, not the IVC size. So here again, it is not more than 50%, less than 50%, as is seen by many people. It should be either more than 75%. If it's collapsing more than 75% with respiration, yes, the patient will respond to fluids. And if it is not moving much, just 10-20%, the patient will not respond to fluids. So that is about the IVC. And the other thing is PLR, passive leg raise test. Passive leg raise test is to be done with the automated bed with a cardiac monitor. So it is a very sophisticated test which is not practical in most of our ICUs. What can be done actually at the bedside is you raise the legs to 45 degrees, and in this what happens is that the blood is returned from the legs to the heart. Okay, so when you raise the legs, the blood which is there in the legs will go up to the heart. So it's like giving a fluid challenge. And when you do this, you look at the blood pressure at the end of 1 minute, whether the blood pressure is improved and whether the pulse pressure is improved. So you look at these things, and if that is happening, that means that the patient will respond to fluids. But it is very important to note that the patient should not develop tachycardia during this test, because if it develops tachycardia, that means there is sympathetic stimulation, and if there is sympathetic stimulation, this test is negated. So that is how you can actually do PLR at the bedside if you don't have automated beds and cardiac output monitors, which are present only in some really advanced ICUs. Now, how to give fluids after the initial bolus with limited hemodynamic monitoring. So one can look at a rise in the pulse pressure with a fluid bolus. So if the pulse pressure is rising, you can be sure that the patient will respond to fluids. But if the pulse pressure does not rise, it does not mean that the patient will not respond to fluids. Pulse pressure is the most sensitive out of all the blood pressure parameters, more than systolic pressure, more than MAP. Then if the MAP is rising and there's a falling heart rate with your fluid bolus, that means the patient will respond to fluids. If the CVP is less than 4, I already told you, and if there are gross respiratory variations in CVP, then that again indicates that the patient will respond to fluids. Or if the CP does not rise with fluids, that means that the patient will respond to fluids. You are given a fluid bolus and the CVP has not risen, that means the patient will respond to fluids. Then if there is a gross variation in pulse pressure variation, even in non-ventilated patients, it will mean that the patient will respond to fluids. Like I told you, pulse pressure variation is classically seen in ventilated patients. But all patients may not be ventilated, but they have an arterial line. So if they have an arterial line, you can look at the arterial trace, and if there's a gross variation in the pulse pressure, that means they will respond. Then clinically, again, you can look at urine diuresis after the fluid bolus. You can look at decrease in capillary refill time. You can look at IVC collapsing, I told you, and an increase of 20% PP with PLRT. Now, this is what is meant by swings in the CVP. So if you can see here, the CP is swinging with respiration, and if the CP is swinging with the respiration, that means the patient will respond to fluids. Now, if the CP rises and stays increased by greater than 4 mmHg after your fluid bolus, that means this patient is already full and fluid should not be given. So you give a fluid bolus and see the response of the CVP. Okay, if the CP stays the same, that means he will respond. If CP rises and falls, that means this is at borderline. If the CP rises and stays risen by more than 4 mmHg, that means this patient will not respond to fluids. Don't give him fluids. Then if you can use the ultrasound that is focused, appearance of B lines with fluids, or if they're already B lines, don't give fluids to this patient. This patient is already overloaded. Then clinically, if you can assess for Krebs, which is very difficult to do in very sick patients, you have to turn them. You can should not be giving fluids. And if there's a lack of increase in MAP, pulse pressure, urine output, again, this may or may not indicate lack of response to fluids. If the patient has ARDS, abdominal compartment syndrome, you should not be giving him too much fluids. Use vasopressors. And in cardiac patients, one has to give fluids in a lesser amount, more slowly, and with more intense monitoring. Cardiac patients, CHF patients, historically, if they come with septic shock, they will require fluids because there will be a depletion of the intravascular compartment. But here, careful assessment of the fluid requirement, give the fluid slowly and give smaller boluses. Now coming to vasopressors. So as I told you, noradrenaline is the first vasopressor in most cases. The exception being if the patient already has significant tachycardia or atrial fibrillation, there you may start with vasopressin. Otherwise, vasopressin is added after noradrenaline is reached 0.25 microgram per kg. That is on the basis of the trials. And if after adding vasopressin at the dose of 0.04 units per minute, the blood pressure is not stabilizing, then there are some newer vasopressors, angiotensin, which is not yet available in India, but is being widely used in Europe and America, and soon it shall come to India. And the other drug is methylene blue, which is being used now after some trials. Epinephrine is not to be used for increasing the blood pressure. The only role for epinephrine is if there is cardiac dysfunction, that is the EF is low, then epinephrine can be used for its beta-1 action. And the other drug is dobutamine, which is actually an inotrope. So if there's septic cardiomyopathy, that is low EF, low cardiac output, then you can use dobutamine to add it to ongoing norepinephrine to increase the cardiac contractility. Now, angiotensin 2 and methylene blue, which I mentioned. So how does angiotensin 2 act? It acts on angiotensin 2 receptors, and it acts because it has been seen that many patients have decreased angiotensin levels and there is downregulation of these receptors. So in most of the studies, it has been seen that it increases MAP in at least 70% of the patients, and there's minimal increase in cardiac output. Some patients get tachycardia, and there's an improved GFR. So it also has a beneficial effect on renal function, and there's faster liberation from RRT. As far as methylene blue is concerned, it inhibits the formation of nitric oxide by inhibiting nitric oxide synthetase. And small trials have shown it can increase BP. It has a beneficial effect on BP in septic shock patients. However, whether it improves the outcome, whether it improves the oxygen delivery is not known. Larger trials are needed for methylene blue, but people are using it because it has a beneficial effect on the blood pressure. The downside of methylene blue is once you give methylene blue, it interferes with saturation, the pulse oximetry. You don't get proper readings. And it also causes green discoloration of the secretions, especially the urine. Now, you are resuscitating the patient, you're giving fluids, you're giving your vasopressors, you're trying to stabilize the blood pressure. What parameters do you use for tissue perfusion? So CRT now probably is the best tool to see in these patients, and once you target a CRT, that is capillary refill time less than 3 seconds. And one can also look at lactate, though lactate is not as useful as it was thought to be, because the lactate can be increased because of many reasons and is slow to respond to fluid administration and vasopressor administration. But if at 8 hours your lactate has decreased by approximately 50%, these patients have a good prognosis. And if your lactate starts rising and if it's not really falling at 8 to 12 hours, one should look at the reasons why lactate is not improving. Okay, sometimes there are hidden foci of infection also, and one has to be vigilant to all this. Then about the venous saturation. So you can draw a sample from the central line and see the saturation, venous saturation. So targeting a saturation around 70% of the venous blood, that is the venous saturation, is associated with a good outcome. And if the venous saturation, that is the SCVO2, is less than 65%, that means your oxygen delivery to the tissues is inadequate. There is no question about that. You have to improve the cardiac output, the oxygen delivery. And when you look at SVO2, you also have to look at saturation. The saturation should be more than 90-95%, because that is what you're delivering to the tissues, and venous saturation reflects how much tissue has been how much oxygen has been extracted by the tissues. So a number of around 70% for SCVO2 is good for your patients, and you should kind of target that. Then the last thing is CO2 gap. That's the difference of the partial pressure of carbon dioxide between the venous blood and the arterial blood, and this should be less than 6. If this is more than 6, that means that the cardiac output is inadequate most of the times, or there is microcirculatory stresses. So these are the parameters one looks at. One parameter sometimes may not be enough, and one has to have a holistic approach. One has to look at all this along with your dynamic parameters of fluid assessment in terms of giving fluids and vasopressors. And this was, the Andromeda shock trial, which looked at capillary refill time. It was a very nice trial and a famous trial. And these are some of the references and papers which refer to lactic acidosis, the venous gap for carbon dioxide, and understanding lactate, and also the SCVO2. Now, the capillary refill time, for those of you who have never done it, it is a very nice bedside test, and it does not cost anything to the patient. You need a glass slide. Take the finger and press it on the ventral side till it blanches. Once it's blanched, keep it there for 10 seconds, then remove it, and after that, see how much time, how many seconds it takes for the blood flow to return, for the finger to become pink. That's all. Is as simple as that. There are many caveats to that, but that is how actually it is done. So all the details I have put up here, you can actually review it in the video if you want. The fluids is very important, and it's like watering a plant. If you give too less, they die, and if you give too much, they wilt. And you do not want your patient to wilt, to die. So please be careful with the fluids. And for fluid resuscitation, Professor Malbrin, who is the founder president of the International Fluid Academy and who is a real expert on fluids, has given this acronym. R stands for resuscitation, O for optimization, S for stabilization, and E for evacuation. So resuscitation is a bolus. After that, you assess for fluid responsiveness and optimize. And after that, you put on maintenance fluids and enteral feeding. And evacuation of fluids is required in some patients because you'll be giving excess fluids, and fluids can be harmful because they cause edema in various tissues. So if the patient, after the shock has resolved and sepsis has gone down, it is 4, 5, 6 days into the disease, into the illness, then there can be need for evacuation of fluid, which may be done with Lasix. You can give some albumin along with that. Or if the patient is on dialysis, you can use CRT to remove the fluid. All patients do not require removal of fluid, but if there is some lingering organ dysfunction, patient is not doing well, this can be because of too much fluid, because whatever fluid you are giving in causes edema of the tissues. For example, the heart may become edematous, its contractility may decrease, the kidneys may become swollen, and the creatinine may keep on creeping. So these kind of things can happen, and one must consider them. Now, a word about the warm stage of septic shock or the hyperdynamic circulation. So do all patients present with bounding pulse, that is hyperdynamic circulation and septic shock? I had talked about this in the first few slides. So this is incorrect, and data from 2 large echocardiographic studies in septic shock was compiled, and this is a dendrogram here which is showing the data. And as you can see here, LV systolic dysfunction was seen in 17.7%, and patients with RV failure had they were around 22%. So this comprises 40% of the total patients. So as you will understand, if there's LV or RV dysfunction, you cannot have a high cardiac output. And for hyperdynamic circulation, you need a high cardiac output. So this particular statement that all patients with septic shock have hyperdynamic circulation, patients with warm shock, which is continuing in textbooks in various literature, is wrong. These are the various phenotypes of presentation as far as the hemodynamics is concerned, and one must be aware of this. Now coming to ventilation. So shock is a state of O2 crisis, and we have to manage the respiration also, and respiratory support has to be provided either by oxygen mask or high flow nasal cannula or NIV, and these are the various modalities. So depending on the kind of problem you are having with the patient. So if the patient is having a mild kind of shock, no real organ failure, respiration is too bad, you can kind of go along with the green light, that is maintain him on oxygen mask or with your high flow nasal cannula. If the patient respiratory system is distressed, respiratory rate is relatively high, shock is not that bad, but not mild either, you can try NIV with close monitoring. But if the patient respiratory system is bad, 35 to 40 RR, is kind of sweating or obtunded, or there's multi-organ failure, you have to intubate the patient. There's no place for NIV here. Please remember, delay in intubation and ventilation leads to death. This is very, very important. I've seen so many times patients with frank shock or 2 vasopressors with multi-organ failure, they are being maintained on NIV. This is only harbinger of death. You have to put the patient on the tube, on the ventilator. Why this is important is because, one, these patients will become obtunded and they will start pulling secretions in the airway. Second is, when the respiratory rate is so high, 40% of the blood is diverted to the respiratory muscles. And shock is a state where there's inadequate flow to the other organs. So when you ventilate, you can take over the respiration of the patient, you can give rest to the respiratory muscles, and blood flow can be diverted to the rest of the body. So these are the two primary reasons. And if you do not intubate these patients who are bad, this increases the mortality. And this is a common practice to keep the patient on NIV, because intubation in these patients is delayed in many settings I have seen. Now, around 24 hours has been reached, and you have to assess the patient. You are assessing the patient continuously, but the patient is not improving. So what are the reasons? So either there's a wrong or a suboptimal dose of antibiotic, or the organism is resistant, or there's a focus of infection which needs drainage. That is, you're having a surgical kind of a sepsis, or he does not have sepsis, or diagnosis is wrong, or some complication has developed, or there's inadequate supportive therapy in terms of fluids and other things, or the patient has started developing resistance to your antibiotics. Initially, he was susceptible, but at around 24 to 48 hours, resistance can develop. Now, moving on to acute kidney injury. As far as acute kidney injury is concerned, we have to dialyze the patient sometimes. And what are the indications for dialysis? So there are the classic indications such as hyperkalemia and acidosis and pericarditis, uremic encephalopathy. So those you are well aware of. And there's this question of when to intervene, early dialysis or late dialysis. So early dialysis is actually the classic indications. That's early dialysis. There's no other strict or clear definition what is early dialysis. The only clear indication for early dialysis when you don't have these classic indications is fluid overload. So it has been seen if there's fluid overload going on, you should intervene early and remove the fluid. Because fluid, like I said earlier, is detrimental. Do not give excessive fluids. Fluids is a drug in septic shock. And it is on the whole better to avoid early dialysis and wait a little, but don't wait for too long. So it's a clinical decision when to dialyze the patient, and it is a matter of concern, because if you delay too much, mortality increases. If you go in too early, it again increases the mortality. And as far as urea is concerned, though urea is not a classic indication, but many people dialyze when the urea is around 200 also. It's a soft trigger. Now, coming to the treatment of metabolic acidosis. So, metabolic acidosis can be because of renal failure or lactic acidosis. So, as far as lactic acidosis is concerned, again, there's a practice to keep giving bicarbonate. Friends, there is no role for bicarbonate in lactic acidosis. If the pH is less than 7.2, you have to dialyze these patients. This is very clearly written even in sepsis guidelines, and I have put up a reference for you. Lactic acidosis, the pH less than 7.2 has to be dialyzed. Bicarbonate is not going to do anything here. The patient is only going to suffer and mortality will increase. As far as metabolic acidosis with acute kidney injury stage 2, stage 3 is concerned, this Bicar ICU study was done around 5 years ago, and this is quoted in the sepsis guidelines also. These patients with AKI stage 2, stage 3, if they have a pH less than 7.2, these patients can be given bicarbonate, and they are helped because the overall use of RRT decreases in these patients, as can be seen in the Kaplan-Meier curve here. Now, coming to steroids. So there's always been a controversy about steroids, but it is clear that steroids are helpful. All right. So they definitely lead to better outcomes. So once you are starting vasopressin, steroids should be put in 200 milligram per day of hydrocortisone should be given to these patients. And this should be continued as long as shock is continuing. Apart from this, steroids can be used in ARDS as well as in pneumonia patients. Now coming to DIC. So DIC, some new developments have taken place. First of all, we are seeing the emergence of viscoelastic tests, that is TEG and ROTEM. They are being widely used in trauma, in liver transplant, in liver injuries, CLD, ALF, and even in obstetric patients. And their use has been validated in these patients, but in DIC, so far, they have not been validated, and international guidelines do not recommend them. But you see the problem with the conventional PTP APTTs, they start going up once there's onset of coagulopathy. And if you were to understand DIC, initially there's a hypercoagulable state. PT-APTT goes up here also. Further on, as DIC progresses, there's consumption of factors and there's a hypocoagulable state, there's bleeding. The PT-APTT derange here. So you do not know at what stage the patient is in the coagulation pathway. However, if you use the viscoelastic test like TEG and ROTEM, you can see whether the patient is hypocoagulable or hypercoagulable. So that helps you in deciding therapy. And now in just 2025, the International Society for Thrombosis and Hemostasis has come up with some treatment recommendations. And these are that for thrombotic DIC, you can use heparin, antithrombin, and thrombomodulin. Antithrombin and thrombomodulin were being used in Japan for the last 10 years. But again, evidence is the problem. Everybody or everything requires evidence as far as guidelines are concerned. And it's only now that they have recommended their use as for all the patients across the globe. And for hemorrhagic DIC, use tranexamic acid supplemented by FFP, fibrinogen, and platelets. So this is very new, just in 2025. And DIC can be a real problem. Sometimes, we see purpura fulminans, there can be amputation. So kindly use these drugs and manage the patient well. And I would recommend the use of viscoelastic tests, though they have not come up with the guidelines, because again, there's a problem with evidence. Evidence-based medicine has to be there for guidelines to be formulated. Then nutrition. So as far as nutrition is concerned, this is an essential part, often ignored. So once the shock starts resolving and the patient's perfusion starts improving, the vasopressors are down to minimal dose and lactate has started falling, capillary refill time is normalized, then you can start trickle feeds 20 ml per hour enterally, and this should be increased slowly. And at day 7, the patient should be receiving full nutrition, that is 25 kilocalories per actual body weight. And beyond that, it should be continued properly. We have seen, and studies have seen, that patients receive only 50% of the nutritional requirements. And it has again been seen in studies that if there is a deficit of 5,000 calories, it is related to mortality. So if the patient stays for a longer time and you don't give nutrition properly, improper nutrition will add to the mortality. Then stress ulcer prophylaxis should be given to all patients of sepsis and septic shock with the PPIs, and DVT prophylaxis again if there is no significant coagulopathy. Now your patient hopefully gets well and he gets discharged, but there are a lot of patients who will die also in septic shock. It has a high mortality, as you know. So why does the patient die despite getting the right antibiotics and support? One, he develops resistance on treatment, or your antibiotics are not appropriate. He can be immunocompromised because antibiotics is one arm of the treatment. Rest of the arm is your immune function, which helps with the antibiotics to get rid of the infection. So if he's having CKD, CLD in advanced stage or on immunosuppressive therapy, these patients are prone to death. Then another infection is required, e.g. from gut translocation or VAP or any other kind of hospital-acquired pneumonia or infection, or a complication like an abscess or acute myocardial infarction has occurred. Then there comes the issue of drug levels. So there can be in vivo and in vitro difference in culture sensitivity and inadequate antibiotic serum levels. So I mentioned in the beginning, renal failure is one situation where it has been seen mortality is high because of inadequate antibiotic serum levels, or you are dosing inadequately even if there's no renal failure. There are drug interactions, pharmacogenomics, or poor drug quality, because there are so many companies and all the companies do not have the same kind of antibiotics. So this is the reason. These are the reasons why your patient may die despite getting the right antibiotics and support. And lastly, he may not have had sepsis. Like I showed you, 15% have sepsis mimickers. Now coming to emerging therapies. So this is about extracorporeal blood purification. So extracorporeal blood purification is coming up in a big way, and it is recommended for all patients now, and we shall see this here. So this is a very recent report, October 2025 XIGRIS trial, and it has been released by the company. The full details are not out, but Professor Claudio Ronco, who is one of the leaders and the world figures for extracorporeal blood resorption and dialysis, has stated that the results that we see today are a clear confirmation of what we observed more than 16 years ago of the EUPHOS trial. XIGRIS, together with a subset of patients from Euphrates, indicates that heme absorption therapy with polymyxin filter can be effective. So there is a turnaround, or rather what I may say, evidence, clear evidence now with this trial that extracorporeal heme absorption is effective. And this was actually there way back in 2017 also in Euphrates trial, when a subset of patients with the endotoxin assay between 0.6 and 0.9 showed much improved hemodynamics with the use of polymyxin filter. And if we are to use this particular polymyxin filter for extracorporeal blood purification, then it should be used in the initial 24 hours. This is not a salvage therapy. If we use it when the patient is not responding and you think the patient is going to get well, that is incorrect. This is an add-on adjunctive therapy. It gives you time, gives the antibiotics time to act. And if in the first 24 hours patient is not doing well, the vasopressor dose is going up, the SOFA score is going up, the lactates are increasing, that is where you have to use it. And you have to continue using it till your vasopressor dose starts coming down, shock starts improving. So this is an adjunctive treatment and should be used early enough. If you use this as a last-ditch effort, it will not help. Now the other newer thing is IgM-enriched trivalent IVIG. So just IVIG was used a few years back, but it did not lead to improved outcomes. So here I'm talking about IVIG, which is a higher concentration of IgM. So these particular patients who respond to IgM-IVG again have to be chosen. And as you can see at the bottom, these patients have to have an IgM level of less than 80 milligram per deciliter. And again, it has to be used in the first 24 hours, and PCT procalcitonin should be more than 2. So this is again not standalone therapy. This is an adjunctive therapy, and it helps by increasing the opsonization of the bacteria, by countering the endotoxin levels, and by immunomodulation. And this was a Sigma trial which showed that this was beneficial. This is a famous trial, and there are several other meta-analyses and trials. And here I put up a case for you. So this was a septic shock patient in immunocompetent women. And if you can see here in the blue is the IgM levels, and in the red is the norepinephrine. So as you have given IgM levels have gone up, and the norepinephrine requirement has gone down. Then again towards the end, suddenly there's a rise in norepinephrine, probably due to a secondary hit. And again they have given IgM levels. They have given IgM levels have gone up again. Norepinephrine has gone down. So here these patients used IVIGM, and they had measured the IgM levels, and the patient responded from a very sick septic shock state. So consider IgM also. The only problem here is many labs will not be doing IgM levels, so that is definitely a limitation. Now coming to the newer world of AI and the advanced technology that is being used. So this was the classification of septic shock into different clinical phenotypes. So a large database, around 30,000-40,000 patients were studied in this study published in JAMA. It's a famous study, and they were able to classify septic shock patients into 4 groups: alpha, beta, gamma, and delta. And they had different kind of clinical subsets. Lowest vasopressor dose was used in alpha. Beta patients were patients who were older patients with many chronic illnesses. Gamma patients were having pulmonary inflammation and more severe inflammation. And delta patients had septic shock with liver dysfunction. And the prognosis worsened as we went down. So these were 4 distinct subsets that they were able to find in a large cohort of septic shock patients. The other thing I want to just show you is the use of transcriptomes and precision medicine, which is the future. So here in this particular article, they were able to show us that different kinds of mRNAs were being used to classify septic shock into different types of septic shock, whether it was viral or whether it was bacterial, whether it was sepsis actually, or whether it was non-infectious etiology, and so on and so forth. And this was by looking at the transcriptomes, that is the different kinds of RNA, mRNA, RNA or microscopic RNA, and the other varieties of RNA. So this is the future. By looking at RNA, different types of RNA, we'll be able to say whether there is sepsis or the non-infectious cause of the disease, whether there is viral sepsis or bacterial sepsis, and so on and so forth. So this is moving into the future. And finally, just to take home and emphasizing the points, especially the update, consider IgM-enriched IVIG, consider polymyxin-based hemoadsorption filtration, treat hypercoagulable sepsis, DIC, with thrombomodulin and antithrombin and heparin, restrict the fluids, use capillary fill time, consider albumin as a drug, use early norepinephrine, use PCR and not only cultures, do not underdose antibiotics, and consider newer antibiotics, use steroids in shock, ARDS, and pneumonia. Now, this is about evidence. So, a lot of critical care guidelines and treatment depends on evidence because we say evidence-based medicine. But in the words of Jean-Louis Vincent, who is a great professor and teacher and from Belgium, for those of you who may not know, he has quoted this, that evidence-based medicine is not cookbook medicine. External clinical evidence can inform but can never replace individual clinical expertise, and it is this expertise that decides whether the external evidence applies to the individual patient at all, and if so, how it should be integrated into clinical decision. Sepsis is clearly one instance where one size does not fit all. So in a nutshell, one has to look at what the literature says, what the evidence is saying, and one has to understand the physiology, one has to have some clinical experience, and then go ahead with the treatment. Guidelines may not always tell you what is to be practiced because of what Dr. Vincent has said. Because trials are very heterogeneous, you need a large trial in many situations, you need homogeneity in the cohorts, and this is not possible all the time. That is why we do not have so many guidelines telling the kind of treatment that should be practiced. I just told you about IgM and so many other things about DIC, because guidelines need evidence-based medicine, large trials, proper data, which is not always forthcoming. So, my dear colleagues, my dear friends, thank you very much for listening to this talk for 1 hour. I hope I have not bored you. It has been a little longish because the septic shock can be 10 lectures by itself. I try to give you the best evidence. And I would like to thank my God and Guruji Babaji Maharaj. So if there are any questions, I am glad to answer them.
Yes.
So, Dr. Lokesh Gupta, sir, management of septic shock in diabetic patients is kind of more or less the same, realizing that the sugars have to be very well controlled because septic shock patients can kind of go into decay also. So you have to be very careful, just manage the sugars very well, and also realize that diabetes is an immunocompromised state, and immunocompromised state depends on the duration of diabetes and the degree of glycemic control. So the rest of the things kind of remain same, and also you have to give slightly more potent antibiotics to diabetic patients if you think they are immunocompromised. So Dr. Bharat Bhushan, sir, as far as two antibiotics are concerned, like I said, you have to look at the antibiogram of your ICU, what kind of cultures you're getting, what kind of bugs you're getting, what is the sensitivity. That is the best way to go about it. And also depends where you are working, whether you're working in a peripheral center or your patients are being referred to a tertiary center. So if you are requiring antibiotics still and you do not know the antibiogram, I would recommend meropenem, one, and along with meropenem, you can go with another gram-negative cover. So if you have, for example, you have what you call pneumonia, then probably you would go with the macrolide or doxycycline. And if you have something like soft tissue infection or intra-abdominal infection, you would like to go with tigecycline. And if you have something like what you call a urinary infection, you can add fosfomycin. So it depends actually, from situation to situation. So Dr. Jitu Thomas has asked how many hours of giving fluid lactate should come to half to tell that the patient is having a better prognosis. So Dr. Thomas, at around 8 hours, lactate should be less than 50%. 8 hours of fluid resuscitation and vasopressors, if your lactate is 50% of baseline, that means that the patient has a good prognosis. And the lactate actually is very variable. For example, if there's liver dysfunction going on, then the lactate will not fall appropriately. If there's renal dysfunction, again, it may not fall appropriately because 30% of lactate is metabolized in the liver. But by and large, if you are giving the fluids and the patient is doing well, and if the lactate is 50% at 8 hours, that means that the patient has good prognosis. When to give cefepime in sepsis? So cefepime is not really a good drug, and I would not give it in sepsis. It is not going to help in sepsis because there's too much resistance. So if you have to start with meropenem at least as a single drug, and accompanying drug can be, as I said, and of course depends on the site also. And the other thing is one has to look at the newer antibiotics also. So newer antibiotics can be used in certain situations, but I did not say that because they have not come into so much widespread use and not so easily available. And cefepime, I would not recommend, Dr. Thomas. Don't use cefepime. So which penem should be avoided titrated in CRF patients to avoid seizures? So Dr. Bharat Bhushan Agarwal sir, the imipenem should never be given because this has a high seizure potential, and you should avoid meropenem. Dose should be modified. Meropenem is okay, but the best drug probably would be doripenem here, which is underused. Doripenem has almost a nil seizure causing potential. Doripenem. So use doripenem in patients with renal failure. It is underutilized carbapenem. Severe LV dysfunction, sepsis, IV fluid, decay, severe LV dysfunction, decay, fluid enlighten. So, Dr. Narasimha, if there is severe LV dysfunction and if there is sepsis and IV fluid bolus, decay, please enlighten. So, this patient has to be managed with advanced cardiac monitoring. It would be very difficult to manage this patient without cardiac monitoring, and you have to have advanced cardiac monitoring and look at the parameters. Managing this patient blindly without advanced cardiac monitoring would be hitting your wall against the head against the wall, and this is very difficult, and you just have to put in cardiac monitoring. Other than that, you give the fluids, and like I told you, you can try and use the CVP and other parameters, but patient with severe LV dysfunction, decay, needs advanced cardiac monitoring. You cannot manage him without that. So coming to the other questions. So role of vancomycin in sepsis. So as far as sepsis and vancomycin is concerned, if you think there is a staph infection, right? Staph would be probably skin and soft tissue infections, or there are multiple abscesses and certain other situations where the patient is predisposed to staph. Therein comes in the role of vancomycin, and vancomycin is better than teicoplanin. There's a tendency to use teicoplanin, but vancomycin is better. And if you have your lab which can do vancomycin levels, it is the best drug for staph. Otherwise, you can use the nomograms also, which are available. So vancomycin role is if you think there is a staph infection, and it should be used upfront itself.
So a question has come up. The first.
Yeah, so I'm just seeing the questions. So, Dr. Gautam, you asked commonest pathogen in UTI. So, it depends on community acquired and hospital acquired. Community acquired E. coli is the commonest infection, and as far as antibiotics are concerned, again, there are various antibiotics for UTI. You can use any of these. It again depends on the antibiogram. Like I told you, you have to look at the antibiogram given by a microbiologist at the sensitivity of the organisms which are coming to your ICU. But generally, you can use fosfomycin, you can use carbapenem, you can use either of these, you can use even colistin. So these drugs are good for E. coli in the UTI patients. So, Dr. Kulkarni, you asked for management of sepsis in children under the age group of 5 years. I'm extremely sorry, but I'm not a pediatric intensivist. I don't see pediatric patients, so I shall not be able to answer that. Sorry for that. So, are there any other questions?
Yes, sir. Just
tell me.
a couple of more. What is the drug of choice for sepsis during 33 weeks of gestational age for pregnancy?
So for 33 weeks gestation, you can use carbapenems. Carbapenems can be used in pregnancy, and of course, you always have to tell the patient there can be some side effects, but carbapenems can be used in pregnancy.
Dr. Josephine has asked, patient is in DIC with type 2 diabetes, empirical antibiotics for MODS. What should be given, and should we also give an antifungal?
So again, we are discussing antibiotics. So antibiotics, I can say one again. I am repeating. There is no particular one antibiotic or two antibiotics empirically. One has to look at the antibiogram. I'm sure all of you are working in places where there is a microbiology lab. If you're not having antibiograms, tell the microbiologist to give you an antibiogram. Antibiogram is composed from the various cultures collected over the last 6 months. It tells you what organisms you are getting and what is the culture sensitivity. And this varies from ICU to ICU and setting to setting, whether you're in a peripheral hospital or a tertiary hospital. But generally, again, I repeat, you have to use carbapenem upfront and you have to add one more antibiotic along with that, depending on the site of infection. So that is what you would like to give for a patient with DIC with type 2 diabetes. And the only thing is, if he's in DIC, you would like to avoid cephalosporins because cephalosporins can impair the coagulation process. And the other thing is, you have asked for antifungals. So antifungals are not to be given initially in patients with diabetes. Antifungals are given to patients if they are having neutropenic sepsis. That is one situation, and the patient has not responded to initial antibiotics. Secondly, you give antifungals if there is a clear fungal infection. Sometimes there can be a clear fungal infection like aspergillosis, etc. Again, this is seen in hematology patients. Then antifungals are given if you are getting cultures positive. For example, Candida is growing from somewhere, then again you may give antifungals. Or if the patient has stayed in the ICU for a long time and he gets a secondary hit, he's on TPN, he's on lines, he's already received antibiotics, and he develops fever and low grade sepsis, then here you may consider antifungal. And if the patient is in shock, you have to go in for caspofungin. Otherwise, you can give fluconazole. So again, that is the situation. But upfront, a patient with DIC with type 2 diabetes will not require antifungals.
Yes, sir. I'll just take two last questions in the
Yeah.
interest of time. Dr. Narasimha asked astironam and ceftazidime for an avibactam in lung patients.
Yeah, so uh, ceftazidime plus avibactam and the combination of astronam is a very potent combination because it covers resistant bacteria and it is primarily targeted at gram-negative infections, and it covers the resistance patterns because you add avibactam and then you add astronam, and it should be used, but it is to be used only as a secondary line, not as a primary line, and mainly for hospital-acquired infections because it's a potent drug, and if you start using it upfront in community-acquired, the patient will start getting resistance. So initially, you should try and use meropenem and colistin and polymyxin and such drugs. But if the patient is not responding to this, then you can go ahead with this. Definitely, it can be used for serious resistant infections of the lung. No question about that. It's a good drug. It's a very good drug with a wide coverage.
Yes, sir, definitely. So last two question,
Yeah, yeah.
just one word questions is what is the best steroid for septic shock, and what is the best antibiotic for septic?
So the best steroid is hydrocortisone. Yeah, IV hydrocortisone is to given as 200 milligram per day in 4 divided doses or 3 divided doses. There are some trials looking at the addition of fluorocortisone, but this is not yet come into the mainstream. Fluorocortisone is being looked at, but the recommendation right now is only to use hydrocortisone for septic shock, 200 milligram per day in divided doses. And what is the best antibiotic?
Yes.
So there is no one antibiotic which can be called best, but if you were to use, then probably meropenem would be the single most important antibiotic for septic shock.
I think so. That brings us to the end of the question answer and the session as well. Thank you so much for an insightful session today. And as you can see in the comments, there have been a lot many appreciative comments for the session.
Yeah. So thank you, dear viewers. Thank you for joining in and for interactive session. Thank you so much. Thank you, Dr. Sanika. Thank you so much.
Thank you so